All right, friends, now let's move on to our next set of questions here. We have question number 154 here. Ideal contraceptive in case of the following scenario. Now, the picture is familiar to you. In the same set, we have similar picture. This is a molar pregnancy, and in molar pregnancy, I told you earlier as well that the contraceptive of choice is oral contraceptive. Barrier method has high failure rates. It is not a contraceptive of choice. Copper T, there is risk with copper T or any other intrauterine device. There is risk of perforation if there is any invasive mole, and also that there is with Depo-Provera and with copper T there is risk of irregular bleeding, and then that will interfere with our diagnosis of gestational trophoblastic neoplasia. Barrier method, on the other hand, oral contraceptives are the contraceptive of choice. Earlier, it was thought that oral contraceptives, they increase the risk of developing post-molar GTN, and those risks are now unfounded, and oral contraceptive is the contraception of choice. Now, question number 155 here. Nerve commonly involved in this obstetric procedure. This obstetric procedure that is happening is McRoberts maneuver. Now, if you clearly see this, if you see this figure here, this figure is, I find it very interesting and important because it helps us see two things. It helps us see McRoberts maneuver, which involves flexing the thigh over the abdomen, involves abducting the hip. Okay, abducting the hip joint, flexing the thigh. We can see one person is doing this here and simultaneously giving suprapubic pressure here. Obviously, the other person, the second person, is required to do that to the other thigh. So I told you minimum of 2 extra person and 1 person who's conducting the delivery, so 3 people. So minimum of 2 extra people are required to conduct this delivery. And what is this inset showing? This inset is showing that when you do this maneuver, what happens is that the symphysis pubis here, is shifts upwards. Okay, so another important thing to remember is that the symphysis pubis here, it shifts upwards. Okay, it shifts upwards, and the lumbar lordosis flattens. The lumbar lordosis flattens. All right, now this McRoberts maneuver, if they ask you, does it increase the pelvic dimensions? It does not increase the pelvic dimensions. It does not increase the pelvic dimensions. It just tilts the pelvis upwards. It just straightens the lumbar lordosis, flattens the lumbar lordosis, and that procedure, that effect of that is that the anterior shoulder, which is hinged beneath the symphysis pubis, is set freed. All right, so it does not increase the pelvic dimensions, but it shifts the symphysis pubis upwards. Lumbar lordosis is flattened, and that unhinges the stuck anterior shoulder behind the symphysis pubis. And the nerve that is damaged in this maneuver is the lateral cutaneous nerve of thigh. Damage to that nerve can cause meralgia paresthetica. Okay, now very importantly, I want you to remember that this lateral cutaneous nerve of thigh, which is damaged in this maneuver, is not damaged in the thigh. It is damaged because of this hyperflexion of the hip joint that is achieved. It is damaged beneath the inguinal ligament. All right, and it is not damaged in the thigh. The nerve which is damaged in the thigh is usually happens with prolonged deliveries when the legs are kept up in stirrups in the lithotomy position here, when the legs are kept up in stirrups and tied during the procedure of delivery, and that nerve is common peroneal, that is involved in the, if they ask you which is the most common nerve involved in obstetric injuries, is the common peroneal nerve, and involvement of this nerve leads to foot drop. Okay, moving on to the next question. A 30-year-old is 14 weeks pregnant. She had 2 painless deliveries at 16 weeks earlier. Next line of management is, oh my god, cervical conization is out of the question. Evaluation for diabetes and thyroid disorders. Cervical length assessment and tocolytics, right? So the answer to this question is cervical length assessment. Diabetes mellitus and thyroid disorders, we don't want to evaluate. Why? Because I told you, anyways, for diabetes mellitus particularly, there is no evaluation. The question here is recurrent pregnancy loss, recurrent second trimester pregnancy loss, 16 weeks. Classical painless deliveries. The question itself is giving you the answer here. It is talking about cervical incompetence. It is most likely talking about cervical incompetence. Therefore, the next line of management will be cervical length assessment. Tocolytics, right now she's 14 weeks pregnant. It's not like her uterus is contracting or anything. So tocolytics is out of the question. Cervical length assessment is the next line of management, and there are 2 painless deliveries. Now, why are we not offering cerclage here? To offer cerclage, she should have 3 recurrent abortions, all right? Whenever that is called as history indicated cerclage, that is called as history indicated cerclage. For that, at least 3 painless, this thing should be there. 3 painless deliveries consistent with cervical incompetence should be there. So let me just give you an overview. Whenever there is cervical incompetence, women can present with a history of cervical incompetence, or like history of cervical incompetence would be painless deliveries, classic history of cervical incompetence, painless deliveries, or she could come in emergency with dilated cervix, right, and short cervical length. So whenever she comes in emergency with dilated cervix, with short cervical length, then what can be done? Emergency cerclage. Okay, emergency cerclage is a procedure that can be done anytime, and usually it is done less than 24 weeks. Usually less than 24 weeks. If the pregnancy is less than 24 weeks, then only usually emergency cerclage is also done. Now, when you do emergency cerclage, the way of putting cerclage is called as worm's suture. Worm's suture. WURM, worm suture. And in worm suture, like if this is a cervix, dilated cervix, the way of putting a suture is like this. This is tied here and this is tied here. So 2 stitches are applied, that is called as a worm suture. This is called as emergency cerclage. Emergency cerclage is done in an emergency situation. It can be done anytime. It is usually done whenever the pregnancy is less than 24 weeks. Beyond 24 weeks, it is usually not recommended. People usually do not do it. It is done when a woman comes in emergency with a dilated cervix and a short cervical length. Alright. Now, whenever then she comes with a history of incompetence, painless deliveries, if there are 3 or more than 3 recurrent pregnancy losses pertaining to cervical incompetence, if there are 3 or more than 3 recurrent pregnancy losses pertaining to cervical incompetence, then a history indicated cerclage is done. Okay, then a history indicated cerclage is done. So either she will fulfill this criteria. If there is less than or equal to 2 recurrent pregnancy losses pertaining to cervical incompetence, then in that case USG monitoring of cervical length is begun. Okay, and whenever the cervical length is less than 2.5 mm, that is the closed cervical length. Whenever the closed cervical length is less than 2.5 mm, an ultrasound indicated cerclage is done. Okay. Now again, all these cerclages are usually done up till 24 weeks. Beyond 24 weeks, usually cerclages are not done. So even when we have to do an ultrasound indicated cerclage, the cutoff is cervical length, sorry, this is centimeter, less than 2.5 centimeter at 24 weeks is predictive of preterm labor. Cervical length less than 2.5 centimeter or less than 25 mm at 24 weeks is predictive of preterm labor. Okay, so this is another question here, one more question here which we can remember, that what is the cutoff for cervical length? The cutoff is 25 mm or 2.5 centimeter at 24 weeks is predictive of preterm labor. Alright, that we are talking about the closed cervical length. I will come to that, what do I mean by closed cervical length. So any procedure, any cerclage procedure, be it emergency cerclage, be it ultrasound indicated cerclage, they are all done up till 24 weeks of gestation. Whenever we are doing history indicated cerclage, we are ideally doing it at 12 to 14 weeks. It can be done 12 to 14 weeks, but it can be done anytime. This is 12 to 14, 14, ideally 12 to 14 weeks, but it can done anytime up to 24 weeks. Right, it can be done ideally between 12 to 14 weeks, but can be done anytime up to 24 weeks. So this is about history indicated cerclage. Now coming to the procedure of cerclage, we have two. We have the McDonald suture, McDonald cerclage, which is the more commonly done, and it is the preferred one simply because it is an easier thing to do, more commonly preferred. And then we have a Shirodkar cerclage, which is less commonly done. Now in the McDonald cerclage we use a permanent suture, in the Shirodkar cerclage we use a Marceline tape, and in the McDonald suture, bites of the suture are taken, like bite from here, one bite from here, then one bite from here, then another bite from here, another bite from here. Ultimately the knot is tied anteriorly. So 4 bites are taken, 1, 2, 3, 4 bites from the cervix are taken, and it is closed like this, right? So this is what is McDonald suture. In a Shirodkar cerclage, on the other hand, what is done is a tape is inserted from this end here, and then it is from this end here. So only 2 bites are taken, 1 here and 2 here. Only 2 bites are taken, and this tape is tied anteriorly. And another important thing is that in this the tape is inserted a little high up, and dissection is performed in this area, right? And this tape is inserted beneath the cervical epithelium actually. So it is a difficult procedure to perform, but remember that the McDonald suture is the more commonly preferred technique. Suture is kept anteriorly. It is important. And it is important that you should remember that when you should not do the cerclage. So when is cerclage is contraindicated, or it is usually not done. The cerclage is contraindicated if there is active leaking, if the membranes are absent, if there is any bleeding, if there is uterine contractions. Obviously then cerclage will be contraindicated. If she is in already active labor, then obviously cerclage cannot be done in case of emergency. Like in case of emergency, if she is already in active labor, then cerclage will not hold, there is no role. And in case of an anomalous baby, this cerclage is not supposed to be done. Another important point is, if we have placed this stitch, when do we remove this stitch? And we remove this stitch if she goes in labor, if there is any infection. Again, infection here, active genital infection is another contraindication where we don't put a cerclage. When to remove this cerclage? If she goes in labor, if there is infection, if she develops bleeding PV or leaking PV, and if none of this happen and her pregnancy progresses, then at 37 weeks the cerclage should be removed. So this is important about incompetence, cervical incompetence and cervical cerclage. Let us move on to the next question. Identify the given instrument. This is a sim speculum. This is a sim speculum. Sim speculum is this in this speculum, you have to realize that this is not self-retaining. The only difference is that this is not self-retaining. So if we are introducing it inside, and we are when we introduce it inside like this, what do? That we depress the posterior vaginal wall, and the anterior vaginal wall needs to be retracted by the anterior vaginal wall retractor, right? But the sim speculum, the advantage with this sim speculum is that there is more space for manipulation. There is more space for manipulation, but the disadvantage is that we need an assistant. We need an assistant to hold the anterior vaginal wall retractor, right? Anterior vaginal wall retractor, because this speculum has got only one flange, and with that we can only depress the posterior vaginal wall to visualize the cervix. Anterior vaginal wall needs to be retracted up by the anterior vaginal wall retractor. For that we'll need another assistant, and more space otherwise is there for manipulation. On the other hand, the cuscose is the self-retaining retractor. Cuscose is a self-retaining retractor. There is no assistant is usually required. It has got two flanges which will retract the anterior and posterior walls, and it is the only disadvantage is that there is less space for manipulation. There is less space for manipulation of instruments. Okay, so this is about the two different types of common types of speculums. One is sims, one is cuscose. Let us move on to the next question. All of the following are true about appala except. Now, antiphospholipid antibody syndrome, I told you, again it has a diagnostic criteria which is called as the Sapporo's criteria. In the Sapporo's criteria, modified Sapporo's criteria, we have the three clinical, we have to have one clinical or one lab parameter. Lab we have discussed earlier in this setting. In the preceding discussion, we have discussed about the lab criteria of appala. Clinical criteria of the other of appala, on the other hand, the clinical criteria can be obstetric criteria or there can be non-obstetric criteria. There is one non-obstetric criteria regarding thrombosis, and obstetric criteria is about recurrent pregnancy losses and about. So this is about the Sapporo's criteria. Remember, it is the Sapporo's criteria for the use for the diagnosis of appala. One clinical or one lab should be there. Among the clinical, there can be non-obstetric clinical features. There can be obstetric clinical features like pertaining to the recurrent pregnancy loss. So I told you that APTT is prolonged. APTT is prolonged. That is true. Okay, in appala APTT is prolonged, that is true. So appala, you know, it's like the lupus anticoagulant. This lupus anticoagulant, the name is saying anticoagulant, all right, but it does not cause bleeding in vivo. In vivo it causes thrombosis. The whole pathology of appala is based around thrombosis. Okay, the main pathology of appala is that it is based all around thrombosis. You have to understand that this antiphospholipid antibodies, In appala there are antibodies against the phospholipids. Okay, where are these phospholipids located? These phospholipids are located in the cell membranes, in the various cell membranes, in the endothelial cells, in the platelets, everywhere. And wherever these phospholipids are, there the antibodies go and bind to these phospholipids. These anti-phospholipid antibodies, these lupus anticoagulants, this anticardiolipin, all these anti-phospholipid antibodies, they go and they bind to the phospholipids, and there what they do, like in the endothelial cell, when they bind, they lead to endothelial cell activation. When they bind to the platelets, they lead to platelet activation. So what they do, that in vivo, in the body, inside the circulation, they cause platelet activation, thrombosis, endothelial activation, endothelial damage, again predisposing to thrombosis. So the baseline, the bottom line regarding appala is thrombosis. The pathology is thrombosis. That is why one of the non-obstetric criteria is thrombosis. Obstetric criteria is recurrent abortions, recurrent pregnancy losses, preterm delivery, pre-eclampsia, IUGR, right? So appala predisposes to pre-eclampsia, appala predisposes to IUGR, and appala predisposed to recurrent pregnancy loss. All of this again because of thrombosis at the placental interface. Alright, maternal fetal interface at the placenta. So there is thrombosis, right? So APTT is prolonged is a true statement. Why? Because in vivo they cause thrombosis, but that is the contrast here. When the blood of appala is tested, these antibodies in the lab, in vitro, cause prolongation of coagulation time. So again, this is a very contrasting statement. I am telling you and emphasizing on thrombosis, thrombosis, thrombosis all the time. I am speaking about thrombosis. But again, when you remember thrombosis, you should also remember that these antibodies, there is a catcher. The catcher is that even though it is all thrombosis when we talk about appala, these antibodies in vitro, these antibodies, they cause prolongation of coagulation time. So it is lupus anticoagulant. This is lupus anticoagulant, right? So as the name suggests, they are called as lupus anticoagulant because they cause prolonged coagulation times. So they actually cause prolonged coagulation times. But even though they cause prolonged coagulation times in vitro, they act like an anticoagulant in vitro. Inside the body, in vivo, they actually cause thrombosis. In vivo, they actually cause thrombosis. So this is an important thing to remember here, that in vivo these antibodies cause thrombosis. So APTT is prolonged is a true statement. Recurrent second trimester pregnancy losses, true statement. I told you appala can lead to recurrent pregnancy losses. Appala more characteristically causes second trimester pregnancy losses as compared to first. Pregnancy loss can occur without other symptoms of antiphospholipid antibodies. That is also true because clinical criteria could be non-obstetric, could be obstetric. So there could be just obstetric complications without any other evidence of thrombosis. Severe life-threatening hemorrhage does not happen. So this is the false statement here. Severe life-threatening hemorrhage does not happen with appala. I told you it is all thrombosis. Hemorrhage does not happen with appala. Moving on to the next question. A young girl presents with primary amenorrhea. A young girl presents with primary amenorrhea, grade 5 thelarchy. What does grade 5 thelarchy mean? Grade 5 thelarchy mean, now this grading of thelarchy and pubarchy, that is given as various grades like 1, 2, 3, 4, 5. They are called as Tanner's staging. Tanner stage 2 means breast budding. So when puberty is just beginning, Okay, Tanner stage 2, when puberty is just beginning, when the breast budding is starting, that is called as Tanner stage 2. Tanner stage 1 is prepubertal, okay, and Tanner stage 3, 4, 5, grade 5 thelarchy means adult breasts, full-fledged breasts. So there are full-fledged breasts, primary amenorrhea, grade 2 pubarchy, and no axillary hair. No axillary hair. The most probable diagnosis is testicular feminization syndrome. Alright, no doubt about that. There is only one syndrome where axillary and pubic hair are absent. Now, in this question, see, in this question, it is not saying pubic hair absent. It is giving you grade 2 pubarchy. What does that mean? Grade 2 pubarchy means, I said Tanner stage 2 is breast budding. So on one hand there is full developed breast, but there is no corresponding grade 5 pubarchy. It is almost as if pubarchy is just beginning, grade 2, very mild, a little more than prepubertal. So some discrepancy there, and there is no axillary hair. Therefore, the diagnosis to this question is testicular feminization. In Mullerian agenesis, axillary hair should be present, pubic hair should also be present. In Turner syndrome, you know that obviously, and Turner syndrome and gonadal dysgenesis, there will be no secondary sex characters, okay. So let me just give you a brief about this diagnosis of primary amenorrhea and how to approach this question such of primary amenorrhea. They're very simple, but again, simple meaning they might be giving you the same questions and again, okay, about primary amenorrhea, because there are very few limited conditions that you have to remember. But again, they can give you, they can twist it around in the form of how they frame the question. Alright, instead of just plainly writing that it is secondary sexual characters present or secondary sexual characters absent, they could give you it in this form, like giving you the grades of pubarchy, giving you the grades of thelarchy. Now again, important aspect is you don't have to remember the entire Tanner staging. You just have to know grade 2 is when the puberty begins, that is grade 2 thelarchy. Alright, when you go beyond like 4, 5, 3, they are all going towards maturity. 1 is prepubertal, Tanner stage 1 is prepubertal. So that is the basic bit to remember. Now I'll tell you what is the approach to primary amenorrhea. Approach to primary amenorrhea. Now, whenever a question is framed regarding primary amenorrhea, you first have to see in the question whether the secondary sexual characters are present and secondary sexual characters are absent, okay. So this is the first thing that you have to see, whether the secondary sexual characters are present, whether the secondary sexual characters are absent. Now, in the secondary sexual, when the secondary sexual characters are present, you have to see if there is history suggestive of cryptomenorrhea. Cryptomenorrhea means hidden menses. Example, like she has history of pain in the abdomen every same time of the month, every time, and this has been happening for a couple of months. That means that there is history of cryptomenorrhea. And if there is no history of cryptomenorrhea, there can be two possibilities. There can be an imperforate hymen, or there can be a transverse vaginal septum. Okay. Now with an imperforate hymen, there will be simply a bluish bulge, can be seen on local examination at the introitus, and the treatment for such a situation would simply be a cruciate incision and let the contents drain. With the transverse vaginal septum on the other hand, this transverse vaginal septum is most commonly located in the upper part, therefore locally nothing will be visible, right. So if there are secondary sexual characters present, so look at this, go through me one by one. If there is primary amenorrhea, secondary sexual characters are present, there is history of cryptomenorrhea, and we don't see a bluish bulge on the introitus, so there is no imperforate hymen, but still we suspect strongly that there could be a transverse vaginal septum. Then the only way to find out whether it is a transverse vaginal septum or no, we can at least do an ultrasound in this situation. An ultrasound will help to see collection of blood above the septum, okay. So above the septum means it could be hematocolpos, it could be hematometra, right. So this could be there. Ultrasound could be one basic step to do, most common in upper part, transverse vaginal septum, and the treatment is septum resection, right. The treatment is septum resection, and you have to understand that before we plan a septum resection, you see, you should always do MRI, before surgery, because MRI helps to see what is the depth of the septum. And so ultrasound can be an initial investigation, but finally it has to be MRI before we plan a surgery. So just a little bit of extra information there. Coming back to the next question here, coming back to the next situation here, sometimes there is no cryptomenorrhea, but on local examination, instead of seeing an imperforate hymen, we can find that there is a blind or absent vagina. Okay, sometimes there can be a blind or absent vagina, and there are only two conditions with blind or absent vagina: Mullerian agenesis or testicular sensitivity syndrome, androgen insensitivity syndrome. In both cases, secondary sexual characteristics are present. So we will see if there are normal pubic hair. I am writing normal pubic hair, then the diagnosis is Mullerian agenesis. And if there are scanty pubic hair, I am not saying pubic hair absent, I am saying scanty or absent pubic hair, pubic or axillary hair, the diagnosis is androgen insensitivity syndrome, and the details of both these have been discussed by me earlier part of the discussions in earlier questions. So I will not go to the detailed discussion here between Mullerian agenesis and androgen insensitivity syndrome. In the secondary sexual, if the secondary sexual characteristics are absent, then we have to see what is the height of the woman, height of the girl. If the height is normal, or if the height is short. If the height is short, the diagnosis could be Turner's, or the diagnosis could be constitutional. Now, constitutional is a diagnosis of exclusion. If the height is normal, so if the question says primary amenorrhea, secondary characters absent, normal height, then the diagnosis could be Coleman's, or it could be gonadal dysgenesis. Between these two, if only this much information is provided to you, that is primary amenorrhea, secondary sexual characteristics absent, height normal. If only these three information is provided to you, the answer should be Coleman's, because Coleman's is a commoner condition than gonadal dysgenesis, okay. Coleman's is a commoner condition than it is a hypothalamic cause. Coleman's is a commoner condition than gonadal dysgenesis. Other than that, if additional information is provided to you, that is FSH and LH are going to be raised in they are going to be decreased in Coleman syndrome. They are going to be raised in gonadal dysgenesis. So if additional information is provided to you, well and good. If additional information is not provided to you, then Coleman's is the answer. Now regarding Turner's and gonadal dysgenesis, Turner's is also a type of gonadal dysgenesis. So when they ask you this question, what is the most common cause of primary amenorrhea? The most common cause of primary amenorrhea is gonadal dysgenesis as a group. But which gonadal dysgenesis? Turner syndrome. Okay, gonadal dysgenesis is a group of conditions where the gonads are dysgenetic. So in Turner syndrome also the gonads are dysgenetic. Turner syndrome is 45XO. There are other forms of gonadal dysgenesis which are rarer. There are other forms of gonadal dysgenesis which are rarer, like we have the mixed gonadal dysgenesis and we have the pure gonadal dysgenesis. The mixed gonadal dysgenesis are situations where there are mosaics, like it could be a Turner's mosaic. One could be 45XO or 46XX. It could be 46XX/XY. This could be one mosaic. Pure gonadal dysgenesis would be 46XX or 46XY. The pure gonadal dysgenesis where the genotype is 46XY, specifically called as Swivert syndrome. Okay, so 46XX is also gonadal dysgenesis, 46XY is also pure gonadal dysgenesis, but the one which is 46XY, that is called as Swivert syndrome, not this. Okay, another important thing that you have to remember, a question can be framed a little differently than this. Another aspects of primary amenorrhea I want to emphasize here. Sometimes there can be a woman with, there can be primary amenorrhea, the girl with primary amenorrhea, absent secondary sex characters, right? And if they ask you question, what is the next step? Then the next step to come to diagnosis, the next step, now height, measuring the height is not a step, you see, measuring the height is not a step. So the next step is perform FSH and LH levels. This is the next step. Why? Because if the FSH and LH levels are raised, or if the FSH and LH levels are decreased. We know that in primary amenorrhea with secondary section, absent secondary sexual characters, that means there is no estrogen. Right? Now we have to find out whether the cause of this no estrogen is hypothalamic pituitary cause or it is gonadal dysgenesis. So if the FSH and LH is increased, it means the gonads are at fault. That means it is either gonadal dysgenesis, Turner's being one of the type of gonadal dysgenesis. Turner's will come with its own stigmata, and or either it is constitution. Sorry, it is gonadal dysgenesis. If the FSH and LH is decreased, then it is a hypothalamic or a pituitary cause. Okay, if it is a hypothalamic or a pituitary cause, you have to see that in the hypothalamic or pituitary cause, it could be a Coleman syndrome, it could be a space occupying lesion, okay. So to differentiate between Coleman's and a space occupying lesion, one needs to do an MRI, to rule out any space occupying lesion in such a situation. Alright, so this is the usual way we go about it. Absent secondary sexual characters, next step is FSH and LH levels. If the LH and FSH is raised, the diagnosis could be any of the gonadal dysgenesis. If the FSH and LH is decreased, it could be hypothalamic or pituitary cause, Coleman's being one of them. The other common cause is space occupying lesions, like for example we can have these craniopharyngiomas, which is one common cause, craniopharyngioma. These are one common malignancies leading to amenorrheas. So space occupying lesion, that can be differentiated by doing an MRI. Alright, in all this scheme, constitutional delay in puberty, or constitutional delay and constitutional cause of primary amenorrhea is a diagnosis of exclusion. Alright, now moving ahead. Question number 160. Now question number 160 is more like a surgery question than a gynae question, but yet it is given here. Let's just discuss it here. Which of the following does not contain fat on mammography? And the correct answer is seborrheic dermatitis. Even if you had no idea about mammography, you should be able to answer this question. Seborrheic keratosis is a condition of the skin. It does not contain fat on mammography. Hamartoma, galactoseals and posttraumatic cyst on the other hand can have fat appearance. Question number 161. In a case of recurrent abortions, we have already discussed recurrent abortions. In a case of recurrent spontaneous abortions, following investigation is absolutely unwanted, and the answer to this question is testing for torch. Moving ahead next, causes of unilateral dysmenorrhea are all except. Now this is also, again, imagine, now this is a rudimentary horn. So unilateral dysmenorrhea obviously will happen because of some unilateral cause, alright. So this is a uterus that has a rudimentary horn. Bleeding into this rudimentary horn can cause dysmenorrhea, okay. Right ovarian vein syndrome, that also causes dysmenorrhea. Unicornuate uterus causes dysmenorrhea, unilateral. A fundal fibroid, large fundal fibroid is unlikely to cause a unilateral dysmenorrhea. If at all, it is going to cause a global dysmenorrhea. So large fundal fibroid is the cause of this unilateral dysmenorrhea. Okay, what is this right ovarian vein syndrome? Sometimes there is pelvic venous congestion, which is more commonly on the right side, happens more commonly on the right side, and that can lead to congestion on the right side, and pelvic congestion on the right side leading to unilateral dysmenorrhea. Moving on to the next question. Question number 163 has been done. Question number 164. Now I have discussed properties in detail with you, so I will just talk a little about this question here. This is a Copperty 380A. Its lifespan is 10 years. This is true. Contains barium sulfate to make it radio opaque. This is also true. Now I told you that the most common side effect is bleeding, and the most common bleeding and pain. Pain is also a significant side effect, and the most common cause of removal, is pain. Okay, so if you consider these two statements, most common side effect pain versus this statement here, I'll have to do this, okay, versus this statement here. So if you were to consider these two statements, C and D, most common side effect pain and associated with higher expulsion rate as compared to medicated IUCDs. Now this statement, D statement, is absolutely false, that it is associated with higher expulsion rates. So this is a totally false statement. Therefore this statement here is your answer. This is a not true statement. Most common side effect pain is, most of the times it is described as that bleeding is a commoner side effect than pain. Pain is the most common cause for removal is pain. However, pain is a significant side effect. Therefore, answer is D, because this is an absolutely incorrect statement. If you talk about various types of IUCDs, Copperty 380A, multi-load, Mirena or anything else, expulsion rate does not differ by the type of IUD, alright. Expulsion rate of intrauterine devices, which includes Mirena, which includes Copperty 380A, so Mirena is the medicated one. Expulsion rate of IUDs does not differ by the type of IUDs. Okay, so what does it depend upon? It depends upon the age of insertion. That means the expulsion rate is more in younger females. Younger females, by younger females, it means between about 19 to 21 years. And usually in our country we are not inserting Copperties in nulliparous women anyways, so it depends upon the age of insertion, more in younger females depending upon the age, not on parity. Again, not on parity, but on age of insertion, which is different from parity. So not on parity, depends upon the age of insertion. Another important factor is the expulsion is more in postpartum insertion, more in postpartum insertion versus interval insertion, and again it is more in post second trimester abortion insertion versus post first trimester abortion insertion. Okay, so these are two important points, that it is expulsion is more in postpartum insertion versus interval insertion, more post second trimester abortion insertion versus post first trimester insertion. Depends upon the age of insertion, not on the parity and not on the type of IUDs. Moving on ahead with the next question here. Question number 165 here. Folic acid required in first trimester of pregnancy in a woman with history of neural tube defects. Now there is a history of neural tube defects, then the dose is 4 milligrams. All right. Now it is 4 milligrams. We don't want any doubts about it. The recommended required amount is 4 milligrams. We in India give 5 milligram tablet. We give 5 milligram tablet to everybody. The tablet that is available in the market contains 5 milligrams. All right. Even women who do have no prior history of folic acid intake are actually getting that 5 milligram tablet. All right. So irrespective of that, you should understand what is the recommendation. The recommendation is folic acid is required in women in the first trimester, in the periconceptional period, for prevention of neural tube defects. So let me just make it clear, make certain points clear. When we talk about periconceptional folic acid, that means 1 month prior to 1 month prior to conception, and that is continued for 3 months. Right. So it is 1 month prior to conception. First important point is that. Next important point is what is the dose. The usual dose or the routine dose for all women is 400 micrograms per day. That is what is recommended. All right. When there is a history of past affection of pregnancy with a fetus with a neural tube defect, whenever there is a past history of neural tube defect, then the current dose becomes 4 milligram per day. Why? Because the risk of recurrence of neural tube defect is 5% with history of 1 neural tube defect, and it can be as high as 10% with history of 2 prior neural tube defects. So this dose becomes 4 milligrams, and this prevents or this decreases the chance of recurrence by about 72%. Very, very important. When we take this dose, it decreases the chance of recurrence by about 72%. All right. So this is much basic about periconceptual folic acid intake. Another important thing to remember about folic acid intake is that this folic acid supplementation does not prevent against all neural tube defects. Very, very important. Okay, neural tube defects is a problem which is multifactorial. A fetus can have neural tube defects because of multiple factors, multiple reasons. Like for example, maternal diabetes is one condition where neural tube defects are. Anti-epileptic drugs, example valproate. Then we have fever in the periconceptional period, hyperthermia. Alright, so these are conditions which also are implicated in neural tube defects. Whether folic acid supplementation prevents neural tube defects because of these causes is unknown. Alright, whether folic acid supplementation prevents neural tube defects in this. So, role of neural tube defects, role of folic acid supplementation here is unclear. Whether it prevents or no is not known. However, it is recommended. The role of folic acid supplementation in prevention is unclear. To control neural tube defects, to prevent neural tube defects from happening in a mother who has diabetes, the appropriate mode is not folic acid supplementation but control of maternal diabetes. If valproate is the cause of neural tube defect, that will stop with stopping this intake of valproate drug. So therefore, the role of folic acid supplementation is unclear in these conditions. Therefore, it is said that folic acid supplementation does not prevent against all neural tube defects. Alright, now moving ahead with the next question. Question number 166 has been discussed while doing twin pregnancy, so we will not do that again. Question number 167. The zone of fibrinoid degeneration where the trophoblast and the decidua meet is known as the Nita-Bush layer, and remember this Nita-Bush layer is absent in morbidly adherent placenta. Whenever this Nita-Bush layer is absent, it can lead to morbidly adherent placenta. This is an important thing. These folds of Hoboken, they are present in the umbilical artery. Okay, they are not present in the umbilical vein. They are present in the umbilical artery, that is folds of Hoboken. So this is again, and Wharton's jelly on the other hand, another important point, Wharton's jelly is present in the umbilical cord. It is the connective tissue matrix of the umbilical cord. It is present in the umbilical cord. So just these important one terms. Now question number 168. A woman has had history of off and on repeated first trimester bleeding episodes, and somehow her pregnancy has continued. She is now 28 weeks, first trimester bleeding. While prognosticating about her further pregnancy outcome, she is told to have increased risk of all of the above. So any woman who survives her first trimester bleeding episodes and then pregnancy keeps on continuing, there is risk of preterm labor, there is risk of IUGR, further bleeding, abruption, right? There is increased risk of, another important thing, also risk of preterm premature rupture of membranes. Again with IUGR, remember another risk of low birth weight. These are other additional risks. Question number 169. The gold standard for estimation of beta HCG is, now the gold standard here is radioimmunoassay. Again, I want to emphasize here that what do you have to remember in beta HCG? Beta HCG again is a very, very important hormone, and this is one hormone that you have to remember. If there are two hormones in pregnancy which you have to remember, one is beta HCG, one is human placental lactogen. The gold standard or the best sensitivity is achieved by radioimmunoassay. So let me just give you one very, very important points about beta HCG. To remember, what are the most important points to remember about beta HCG? You have to remember that it is a glycosylated hormone, and remember that it has the alpha and beta subunits, among which the alpha is common and beta is the specific one. And remember that usually this alpha is the non-specific one, which is shared with the FSH, LH, TSH, and all these anterior pituitary hormones, and between LH and beta HCG, the beta subunit, between the LH and beta HCG, the beta subunit, it differs only by 8 amino acids. So since it differs, even the beta specific, which is very beta subunit, which is very specific to each of these pituitary hormones and beta HCG, specifically between LH and beta HCG, the beta subunit differs only by 8 amino acids. Therefore, wherever LH is used, beta HCG can be used. Therefore, beta HCG is used as an ovulation trigger. Beta HCG is used for ovulation trigger, and it is a glycosylated hormone. The half-life of beta HCG is 24 hours. Remember this. Another important thing that you have to remember about beta HCG: when is it detected in serum and when is it detected in urine? So it is detected in serum and it is detected in urine. Now it is detected in urine usually on the day of missed periods, and we detect in it urine by the urine pregnancy test, and this urine pregnancy test has a sensitivity of about 20 to 25, some say 20, some say 25, both are correct. 20 to 25 MIU per ml, this is the sensitivity of the UPT. To detect in serum, we need tests with better sensitivity, and it is detected in serum as early as 8 days post ovulation. Now if you say 8 days post ovulation, it is the same as day 22 of the cycle in a 28-day cycle, and it is the same as 5 days before missed periods. All right, so whatever you might say, they all signify to the same timing. So it is detected in serum 8 days post ovulation, day 22 of cycle, or 5 days before missed periods, however you might like to say it. Very importantly, again, about beta HCG, you should remember that beta HCG, they start rising. Beta HCG is the first hormone to be synthesized. It is the first hormone to be synthesized by the syncytial trophoblasts, and the beta HCG is synthesized by the syncytial trophoblasts, which are embryonic in origin. So from the embryo, this is the first hormone to be synthesized as early as day 8 of fertilization. So by day 8 of fertilization, when the syncytial trophoblasts are forming, beta HCG synthesized, and the levels start rising, and they reach a peak. They reach a peak at 8 to 10 weeks of gestation, that is 60 to 70 days. So they reach a peak here, and then they decline, and they reach a plateau at 16 weeks. They reach a plateau at 16 weeks, right? So they reach a peak here at 8 to 10 weeks, 60 to 70 days, and they decline at 16 weeks. They reach a plateau at 16 weeks, and they come to normal values. They disappear 2 weeks postpartum. By 2 weeks post delivery postpartum, they are going to disappear, right? Another important point is between this point to this point. Between this point, in the early part, there is a doubling. There is this peak that is called as doubling time of beta HCG. The concentration doubles. This doubling time is 1.4 to 2 days. If you have to choose one, choose 48 hours, 2 days. On an average, it is 1.81. Doubling time does not mean that it becomes double. It actually means that it increases by 66%. It increases by 66% on an average from the previous value. If it does so, it means it is a viable intrauterine pregnancy. Viable intrauterine pregnancy. We have discussed these details while discussing the management of ectopic pregnancy and follow-up of ectopic pregnancy, about the fact that if the beta HCG is doubling, we call it a viable intrauterine pregnancy. Plateauing level goes more in favor of ectopic pregnancy. By plateauing, we means in ectopic pregnancy the levels can rise or the levels can fall. Both of the things can happen, and we have to understand that if they are drastically falling levels, then it means a non-viable pregnancy irrespective of the location. It could be an ectopic non-viable, it could be an intrauterine non-viable pregnancy. So by this we understand what are the conditions where there is increased beta HCG. Increased beta HCG is seen in molar pregnancy, it is seen in multiple pregnancy, it is seen in Down syndrome. So these are the three important conditions where beta HCG is raised. Similarly, decreased beta HCG is seen in abortion, it is seen in ectopic. Decreasing beta HCG, by decreased beta HCG I mean that the beta HCG levels are not as high as in normal pregnancies, and very importantly trisomy 18, there also the beta HCG levels are decreased. Now moving on to the next question. Question number 170 has been done. Just let me give you the correct answer. Placenta develops from chorion frondosum and decidua basalis. We have discussed the placenta in detail. Now question number 171 here. Which organ is the primary site of hematopoiesis in the fetus before mid-pregnancy? So before mid-pregnancy, the primary site of hematopoiesis is actually the liver. Alright, now let me give you a very brief description about fetal hematopoiesis and important points you should remember about fetal hematopoiesis. Let us just summarize here about fetal hematopoiesis. So fetal hematopoiesis, in the first 2 weeks of life, the fetal hematopoiesis happens, fetal hematopoiesis begins at 2 weeks, of life, and between this 2 to 8 weeks it is done by the yolk sac. Okay, and from the yolk sac we get the primitive hemoglobins, right, and we get the GOAR 1 and 2 and the Portland types of hemoglobin, which are the primitive hemoglobins. And after 8 weeks, the yolk sac is no longer forming the hematopoiesis, it shifts to liver. After 8 weeks it shifts to liver, and the liver has forms the gamma chains. Okay, from the liver we get the gamma chains. So in short, we get the hemoglobin F from the liver. So you should understand that after 8 weeks we get in the liver. Then you have to remember that question is asked, when does the switch from liver to bone marrow happens? Okay, when does the switch from liver to bone marrow happens? Now the switch from liver to bone marrow happens, again I told you till mid-pregnancy it is liver, so somewhere near mid-pregnancy the switch is happening, and somewhere near mid-pregnancy means somewhere around 20 weeks, 40 weeks is pregnancy, so somewhere around mid-pregnancy, remember it that way. So, okay, so mid-pregnancy the switch is happening, so the switch happens at 20 weeks. So what happens at 20 weeks? At 20 weeks HbA, okay, the bone marrow is able to synthesize the beta chains. The bone marrow is able to synthesize the beta chains. So HbA starts forming. HbA starts forming by 20 weeks, starts forming at 28 weeks, but this production speeds up at 30 weeks. Okay. Similarly, if they ask you this question, when does HbA2 production begins? HbA2 production begins at 35 weeks of gestation. And at birth, we have 80% of fetal hemoglobin, the gamma chains we get from liver, and 30 weeks after birth. 30 weeks after birth, there is HbF is only less than 2%. Okay, so by 30 weeks I mean another 6 months. Okay, now moving on to the next question here. Question number 172 has been discussed. Question number 173 also has been discussed already. So we will move ahead in line and try to see what are the questions that have not been discussed. Question number 174 here. Serum progesterone levels which exclude ectopic pregnancy are, now which exclude ectopic pregnancy are more than 25 nanogram per ml. Now this serum progesterone level was suggested as a mode of finding out ectopic pregnancy, because it was suggested that healthy intrauterine pregnancies or healthy placentas should synthesize more progesterone, alright, and whenever there are unhealthy pregnancies, then that could signify ectopic, or it could be an aborting intrauterine pregnancy or unhealthy intrauterine pregnancy. Therefore, serum progesterone levels are not used clinically for the diagnosis of ectopic pregnancy. Alright, so serum progesterone levels, they are not diagnostic of ectopic pregnancy. Remember that they are in no way diagnostic of ectopic pregnancy. However, if the values are more than 25 nanogram per ml, they mean normal intrauterine pregnancy. Alright, and whenever these values are less than 5 nanogram per ml, that means a non-viable pregnancy. Now this non-viable pregnancy, irrespective of location. So it could mean an ectopic, it could mean a non-viable pregnancy of intrauterine origin or non-viable pregnancy of ectopic origin. So again, so that is why serum progesterone levels, they are not diagnostic of ectopic. It could be non-viable pregnancy irrespective of location, intrauterine or ectopic, therefore not diagnostic of ectopic. But if they are more than 25 nanogram per ml, they suggest normal intrauterine pregnancy. Now all are included in the biophysical profile and Manning score except vibroacoustic stimulation test. You should know what Manning score is. Manning score is biophysical profile. It has fetal breathing movement, non-stress test. It has NST, it has fetal breathing movement, it has fetal gross body movement, it has fetal tone, and the fifth component is amniotic fluid volume. Remember, it is amniotic fluid volume, not AFI, okay? Amniotic fluid volume, when it is 2x2 pocket, if there is a 2x2 pocket, it is given a score of 2. It is not AFI. AFI is a part of modified biophysical profile. There is a modified biophysical profile that includes NST plus AFI. AFI is the index that is calculated by adding the 4 quadrants, alright, adding the measurement of Likert. Adding the measurement of Likert in the 4 quadrants, that is AFI. So modified BPP includes NST plus AFI, and your entire Manning score includes 5 parameters: NST, fetal breathing, gross body movement, tone, and amniotic fluid volume, not index, and a maximum score can that be of 10. It is an all or none phenomena. Either it is score is given 0 or it is given 2. Next question, saffron colored amniotic fluid is seen in Now, saffron colored amniotic fluid on the other hand is seen in post maturity. We have already discussed this question, so we will move ahead. Question number 177 has also been done. Question number 178, consider the relationship of the uterus, cervix and vagina as shown in the figure. What will you describe this position as? So as you can see here, the angle of anteversion, okay, this is the angle of anteversion, angle of anteversion is the angle between the vagina and the cervix. Okay, so as you can see here, this angle is 90 degree here, and the angle of anteflexion is the angle between the long axis of body of uterus and the cervix, and anteversion is between the vagina and cervix. So if you can see in this figure, the angle between the vagina and the cervix is maintained, but that between the cervix and the uterus is gone. So in this position, the normal position would have been of the uterus would have been something like this. Then this would have been anteverted, anteflex. Normally the angle of anteversion is 90 degree, which is maintained here. The angle of anteversion is less than 120 degree, which is not maintained here. So this position is described as anteverted and retroflexed. Okay, anteverted and retroflexed. Now the angle which is maintaining anteversion, angle which is maintaining anteflexion. Now the ligaments which is maintaining anteflexion is the round ligaments, right? And the angle ligaments which are preventing retroversion is the uterosacral ligaments. Okay, so you remember these 2 points. So the answer to this question here is B, anteverted, retroflexed. Now contraindications for medical method MIFE plus MISO of the first trimester MTP is all of the above. These contraindications are that of medical contraindications of mifepristone. You have to understand, if there is a hemoglobin, if there is severe anemia, we cannot give any any method of termination for that matter. We'll first have to build up, because termination includes blood loss. So we have to have a proper, such a woman if wants to go for abortion will need first blood replacement. Suspected ectopic pregnancy, obviously in ectopic pregnancy we will not give mifepristone and misoprostol. Glaucoma again is a contraindication for misoprostol, so we will not give. So these are the contraindications for medical method of abortion. Increased prolactin levels, like we discussed earlier with prolactin, when we talked about prolactin and lactation and lactogenesis, increased levels of prolactin are associated with raised estradiol. All of the following are strong supports of the uterus except round ligament. This we have discussed. I'm not going to reiterate here. Question number 182, while performing suction and evacuation for an 8-week uterus, there was suction and evacuation, you might have perforated the uterus, you realize during the process. Certain that you have not perforated while using dilators, what is the next step? So remember, the next step in this situation, if we have perforated using the suction, while suction, then the next step is to do an immediate laparoscopy in this situation. And why I choose laparoscopy? Because the patient is stable. Because the patient is stable, you go for laparoscopy. Here nowhere it is written that the patient is unstable, so I will assume that the patient is stable and go for laparoscopy. Alright, if the patient is unstable, then one can choose laparotomy, otherwise laparoscopy, but the patient has to be, the abdomen has to be inspected. Remember, while suctioning, if there is perforation while suctioning, one has to inspect the abdomen, check for any additional damage that has happened while suction, right? And that is possible by laparoscopy if the patient is stable, or laparotomy if the patient is unstable. If there is perforation while dilator, if the perforation is with dilator, then one can wait and watch, because these perforations are usually small and they get sealed on their own by the natural coagulating mechanisms of the body. And if the patient remains stable, she can be observed for a couple of hours and be sent home. You just wait and watch. If patient becomes unstable, if unstable or bleeding doesn't decrease, then we can go for laparoscopy or laparotomy, whatever is feasible as far as the vascular status is concerned. Now question number 183 has also been discussed earlier. Question number 184 has also been discussed. Anyways, question number 184, what does it say? It says the following curve is used in evaluation of RH incompatibility. Why? Because this curve here, anyways, this question is a very old question. These are Liley's graph. Liley's graph were previously used. These were Liley's graph. They were used in to check for the amniotic fluid bilirubin levels in detection of fetal hemolytic anemia. So the answer to this question was RH incompatibility, where fetal hemolytic anemia and was there, and that is why these tests were used. Question number 185, which part of fallopian tube ectopic occurs most commonly? It occurs in the ampullary part of pregnancy. There's nothing explaining to do here. A pregnant woman presents at 33 weeks with placenta previa of a major degree. The fetus is malformed. Which of the following will be the best line of management for her?